Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EUROTIMES. I'm Oliver Findl. Corneal implants of various types are used to treat keratoconus, ectasia and presbyopia. One of the advantages of these implants is the ease with which they can be removed if necessary. Today we will be discussing the reasons for explanting intracorneal inlays and intrastromal corneal ring segments and how to best accomplish the surgery. Our guest today is Prof Beatrice Cochener of the University of Brest, France, who addressed this topic at a symposium. Welcome, Beatrice. Thank you for joining us.
Thank you, Oliver.
You talked at yesterday's symposium on issues involving explanting corneal inlays and implants. First of all, can you briefly remind us what these implants are being used for currently?
Actually, the both belong to what we call the additive surgery, so potentially reversible. They are not removing tissue, but they are completely different in concept. With the rings, we are trying to reshape the cornea. We are putting the rings in the periphery of the cornea, and they are made of rigid material because you are trying to change the biomechanics of the cornea. With the other concept, we are just dealing with soft material, just expecting to change and to correct the presbyopia. Different concept to achieve this goal, but we are completely different in a sense that we are working in the central part of the cornea directly on the visual axis.
Let's start with intrastromal corneal ring segments, such as the Intacs. What are the main problems you encounter that actually require a secondary intervention?
Yeah. So I think that whatever the surgery, we can have an infection. Infection is, I would say, the baseline for any kind of complications as soon as we are dealing with surgery. So infection can be related first to the poor water tightness of the incision. And for the other complications, it's going to be related more to the surgery itself, because you need to be very predictable for the thickness, according to the thickness of these rings, to the perfect depth of the channel. So thanks to the advent of the femtosecond surgery, we changed completely and tremendously the predictability of the surgery.
So that means before the femto era, that was something which was much more common, and now you're seeing it less so.
Yeah, you're right. When we were doing mechanically the dissection of the channel, it was difficult to make sure that we were not too superficial. When you are too superficial, that will lead to an extrusion of the material. When you are too deep, you can even go for perforation of the endothelium. And of course, the more advanced is the keratoconus, because the key indications is ectasia, and the more fragile will be the cornea. So extrusion and perforation are, of course, the key complications. Besides that, centration is one of the key issues with this procedure. It's not always easy to guarantee, because we don't know if we should take account of the central of the cornea, central of the visual axis, or maybe integrate some kappa angle to make sure that you are well located.
So it means even if the femtosecond laser has given you a very exact centration, the one you were planning, the plan may not have been a good one.
Absolutely, especially when you have an advanced keratoconus with the vertex that can be delocated according to the center of the cornea. That can be an issue. And decentration might be not a reason of explant, but for sure it can induce some functional symptoms and even some decrease in the visual performances.
If you would actually remove segments in that case, would you then put them in again in a different position in the same patient, or would you just say, well, we'll just remove them and leave that patient?
I think that in that case, for centration, no other choice than to remove and not to do anything. It's quite difficult to do a second tunnel, because you have the risk of a fusion of the two, and by the way, to get a very large tunnel with no mechanical effect at all. What you can do is, for sure, change a concept to the other. When you, for instance, use a conventional Intacs with an optical zone of 7 mm, we know that these kind of lenses, which are belonging to the first generation, are not as efficient than the second generation with an optical zone of 6 mm, the so-called Intacs SK, quite close to the Ferrara, to the Kera rings, which are the two other concepts. And in that situation, you can remove the 7 mm and go for a second channel and use a second concept. But again, with great care to the location of the channel.
Let's talk about corneal inlays. They're gaining in popularity as a treatment for presbyopia. There are 3 of these: camera, the FlexiView and the raindrop, all of which work on slightly different principles. What do you know about the reasons for explanting these implants?
Yeah, just coming back, if you allow me to say a few words about the concept. So with the camera, you're working with a pinhole. So it's like an artificial iris. So the biomaterial and the concept itself has some differences to the 2 others. The 2 others are made of hydrogel. That means something very transparent and that try to mimic the metabolism of the cornea. For the FlexiView, you're going to deal with some kind of a bifocal inlays when the raindrop is just changing the asphericity as a presbyLASIK is doing, for instance. So having said that, you can imagine that according to the concept itself, the centration appears to be more crucial with the first concept. And that might be one of the reasons for repositioning or even explanting the inlay when it's not well properly centrated, the camera. Yeah, the 2 others, especially the raindrop, is not as sensitive to the pure perfect centration. Of course, with any of this surgery, the perfect management of the interface, as for any lamellar surgery, is a key issue, and it's not so easy to perform because you cannot wash the interface, clean the interface as you used to do with a LASIK according to the hydrophilia of the material. The infection can be also possible, so you need to respect the perfect rules of asepsia to guarantee that it's going to be a clean surgery.
I mean, do you have any general advice for surgeons that would help them to accomplish these explantations? I mean, I would believe it's difficult if this implant has been in there for quite a while. You have to find exactly the right plane, otherwise you will not be able to remove it. Any advice?
Yeah, actually I think that these advices will change according to the strategy. With the camera, nowadays it's possible to use a pocket, and it's quite difficult to go back to a pocket. And it's even worse than for a flap. So I would say good luck to the surgeon, because you need to refine for sure the plan. I think that one of the key issues anyway, whatever the concept, will be the biotolerance of this material inside of the cornea. So a long-term follow-up is required, and what we notice with the time is maybe some evolution of the material first, and maybe of the surrounding area of the stroma, just is of course in relationship to the lens. So I think that the removal shouldn't be a big issue. It's not more difficult in a practical point of view than a regular LASIK. But then what we need to manage in a proper way is the haze that can occur with these lenses. And we are all focusing on the biotolerance in the long term to determine the future of this concept.
So they all will induce a little haze. Is that what we can take?
All, I cannot say all, but I mean, we are still can be surprised by some late occurrence of haze. We'll need still to manage for quite a long term the steroids after the surgery, whatever the concept. So that means that the reaction of the cornea around needs to be taken account, and we need to take care of the follow-up, even if we know that the new biomaterial has nothing to do with the previous generation that were even able to conduct to some melting of the cornea. I'm talking about 20 years ago.
Well, thank you, Beatrice.
Thank you to you.
Thank you for joining us. For more information on this and related topics, please visit us at eurotimes.org.